Just let me know when you can see that. Yep, right, super duper. So we've got 3 presentations today, which great, I'm really looking forward to. We've got Lorna Howie, who's going to talk about the CKD dashboard in primary care. Tim Ringrose, who's going to talk about Cognitant, a digital patient education platform, and Dr. Lynn Sykes, who's going to talk about AKI in the community. We will follow that up with a discussion, really, and just open it to the floor, thinking a little bit about some of the resources, some signposting, what agenda items, what presentations you might like to see next time, and just any reflections on that. I am going to try and keep us to time pretty much because I know people generally have packed diaries. So I would just draw your attention to the next date and time of the next meeting is actually the 20th of November. It was my fault. I put the 25th of November. So it is the 20th next time, and it's the same time, 3 till 4. But we'll just pick up about dates and times later on at the end of this meeting. So I'm just going to stop sharing my screen. And I cannot see whether, is Lorna here?
I am indeed. Hi.
Oh, brilliant. Hi, Lorna.
Hello.
So that's great. I'm going to hand over to you because I know you're going to talk about the radar CKD dashboard for primary care, which I'm really interested to hear about. And I know we're going to have a demo as well as a few slides. So I'll hand over to you. Thanks.
No worries. Thanks very much, Kate. So hi everyone, my name's Lorna. I'm the operations manager from the Radar team. So as Kate said, I've got a couple of slides, but I think realistically we all just want to probably get in and actually see the tool just with how short time we've got anyway. So what I'll do is I'll ask Kate very kindly if she wouldn't mind just sharing these slides with everybody at the end. So it's just got our contact details. That's the main slide that you'll probably need on the end if you've got any questions. But what I'm going to do is I'm going to dive into Radar now. So Radar is an online platform. It is available to all practices, PCNs and ICB staff in the North East and North Cumbria. So if you do want signing up to it, you don't need to pay for it. It's already been procured for you. So you just need to get a username and password through ourselves and I can sort that out for you. I am going to show you a training version today. So it does say paid training and it's got no real practice names or numbers or anything. But what you see is what you will get in the real version, just with your data in it. So primary care dashboard is a class 1 medical device. So along with that comes the assurances that class 1 provides us. It's got all of your data in it. So all of the data in here is extracted from the practice's clinical systems, as well as using some SUS data as well to look at things such as admissions. So we have worked closely with a number of clinicians to develop our CKD screens. So we've worked with Sarah McCluskey and Katie Jones in the first instance to get us over the line. And I don't know if they're on or if they've been if they're included. The work they've just been amazing. They've been so good at helping us and supporting us get where we've got to. So let me take you through how it works. So the first screen is an aggregate view of how are we doing with patients with CKD. So what it lets you look at is it depends on what role you are. So you might be in the ICB and you want to see all of the different sub-ICBs, so Newcastle, Durham, Tees, everything like that. So you can see all the different areas. Or you might be wanting to view it through the lens of a PCN. So you want to look at all the PCNs in the Northeast. Or you might want to deep dive into a PCN and look at the practices within the PCN. Or you might want to view it as a practice. So there's lots of different views that you can see this data at. So you can either build up or you can build down and scale down, not build down, scale down the data. The beauty is everyone's still using the same thing. You're all still using the same page. You're all still accessing the same data. So it should really help with that, I suppose, that single view or single version of the truth with regards to this data set. So what it lets us see in the first instance, I've logged in as a practice. So I'm practice 119. So that big pink bar shows me who I am there. And it lets me see the number of patients that I've got in my practice. We are going live in October with a new version of this screen, which also has a filter here to change it to show you the total population. So what that would show you is not only the percentage of patients with CKD, but what that would mean is a percentage of the total population in the practice. So you might have, I've got 1,402 patients. what does that mean and how many patients do I have overall? So it might be like 2% or it might be like 50%. Oh my goodness. So you can really start to see where your issues are potentially. So you can view it as a practice, PCN, or as an ICB, depending on your role. We can then see the different stages along the top just to very quickly identify maybe an area that you're wanting to look at. So you might have a real interest in looking at, I don't know, stage 5 patients. So you know straight away that's our problem area. Or you might look at the data that we've got in front of us and go, actually, stage 3 is where predominantly most of our patients are. So that's where I'm going to hone in on. The aim of this page is to really try and draw your attention to what the data is telling you. So you don't kind of come in and go, oh, we know we've got a problem with stage 5. But actually, when you come in here and go, well, actually, we don't. We've not got that many patients there. It's actually patients in this area. We can see in this chart here, now again, apologies, it's just fake data, which is why we've not had a big slump in admissions straight to October. I mean, it'd be great if we did, but it is just fake data. What this can let you see is your non-elective admissions over the last 2 years for your patients. So that's how many times your patients have gone into hospital and have been admitted with CKD related an inpatient appointment. So you can see this 12 months, the latest 12 months, and the prior 12 months. So you can see those peaks and troughs. And it's really nice to be able to see. I'll show you one that's maybe got a better, it's COPD, but it's got a better pretend data. So that's what the live one looks like. Do you see the peaks and troughs? You can see, or you can go, oh, why did we have a peak in February? Whereas this February, we've not had any. So it's just quite useful to see. So imagine we had pretend fake data that showed you that kind of drawing on here. We then have a medication chart over here, which lets us look at some new medications. We have got some new medication being added in October, and I'm going to pretend to say it, and I'm going to butcher. It's like finerenone or something like that. I can there's only a few things I can say, and it's allopurinol. It's the only one I can actually say, or paracetamol. They're the two I'm good at. And I'm quite good at SGLT2s now. Nailed that one. But yeah, we've got that new one coming up. So that one's going to be added in October. So this one's really nice as well. It lets you see of your patients how many patients have been prescribed with X, etc. We can then see comorbidities because it is a CKD screen, but we're aware that our patients have other comorbidities as well. So it's really nice to start to then go, of our stage 3 patients, what other conditions are they living with as well? So we can start to look at that. You've got your deprivation deciles. So we can start to see our more deprived patient population, and we have split that into the CKD stages as well. So again, that just has that health inequality view of going, do we seem to have a number of patients moving through the stages quicker in the more deprived areas than any other areas? You can make any of these bigger by just clicking on the little button here, and it just makes it go full screen for you, because I know we do try and cram a lot on the pages for you, but you can make anything bigger. And then if you go, do you know, that's a beautiful chart, fancy that for a report, you can right click on anything and you can download it. You can download it as an image because it's so beautiful, a PDF, or you can extract the raw data. And when you extract the raw data, that enables you to then just take the numbers, the breakdown, and you can use it then for your own analysis. So that'll dump it into Excel for you in that stage. We've got the age groups and ethnicity as well. We are going live in October with 2 Venn diagrams that are going to be added on here. What the Venn diagrams are going to look at, I'll come on to at the end, but what that is going to look at doing is case finding, so adding risk stratification to that aggregate view. At the moment, on the current live dashboard, case finding and risk stratification is only available for practice and PCN users, but we are going live in October with an aggregate view. So what can the practices see? And it's always the one I always say, it's the so what question. This is where that comes alive, because I've told you you've got 234 patients at stage 3. Who are they? Where are they? What's going on with them? What you can do is, you can open your patient page here, and you can then start to say, right, actually, I was interested in those stage 3 patients. So you can come on here and say, I'm interested in my stage 3. There's the 1,000 of them that were on the front page. It would have the clear NHS number. It tells you which practice they're aligned to. So if you're a PCN user and across a number of practices, it just makes sure you know you're looking at that practice that you're meant to. It shows us the age, the sex, and then the CKD stage, sorry, and then some other information. But on this page, what you're able to do is really the point of this one is to slice and dice a cohort that you're interested in. So what you might be saying is Kate might go, oh, do you know, I really want to look at my CKD stage 3 patients that are currently in smoking cessation. Yeah, and they've been referred to social prescribing. How many of them are on a certain type of drug? How many of them have been to A&E in the last 12 months? So you can really slice and dice this data to something that's meaningful for you. Because what we tend to find is a number of, I suppose, national priorities or national guidelines doesn't necessarily, it's not one size fits all. So something that, you know, fits brilliantly in an affluent area in Gosforth or whatever might not fit into a deprived area in the deep end of Newcastle, for example. So what this really lets us do is pick what is meaningful to us as a practice, pick what is meaningful to us as a kind of collection of CKD experts. So you can really slice and dice, and you can go, actually, yeah, I don't want smoking cessation. That's got me down too low now. I can get rid of it. Let's add something else. And you can just keep going. You're not having to come back and ask a data team to run another report for you. You can go, I wonder what it would do if I just say I want to look at males only or females only, and you can just really start to explore the data and see where it takes you. So that's the practice view. So this is about exploring and understanding who these patients are. You can extract this information out of Radar and import it directly into the practice clinical system and create a search in System 1 or EMIS. So you can call it, I don't know, Radar search or whatever you want it to called, and then you can run that for those patients and find them as well. But you do have the NHS number. The other thing you can do, just conscious of the time, is the case finding. So what the case finding lets us look at is all of the patients without CKD. So we are totally controlling and managing all the patients with CKD. We're using the tool and everyone is doing great. What the case finding lets us look at is it says, right, you have 17,000 patients, 17,057 patients in my practice that do not have CKD SNOMED codes aligned to them. They've not got any classification of CKD. What you can do is you can come in here and go, right, show me everyone that has got a UACR reading of 30 to 70, because I picked it just because it was there. I've got 27. I've got a GFR reading of that. We've got 3 people here. So what we can see is we can see the age of these people, we can see the gender of the people, we can see what the readings are, we can add lifestyle factors. And basically what this is doing is this is saying, actually, they don't have any SNOMED codes saying they've got CKD. Let's look at these patients on our system and go, do we think they have? When was the last time they were in? Have we seen them recently, or have they not been at practice for a while? Particularly interesting when you actually then just add in like the monitoring as well. You can start to see what's going on with them. You can add in some lifestyle factors as well, because it is all about prevention this stage. I mean, obviously you might find some, as one of our clinicians always says, like low-hanging fruit of people that were just missed, just from a coding point of view. But actually, this is a really good preventative tool as well, because we can train or we can get the staff set up in practices to identify some early indications of CKD, and we can start that awareness early in the patients about lifestyle changes, about all of that information, but also what to be aware of. And we've noticed when we've done this in other products or other disease groups that there's been a real, I suppose, real shift in the patient awareness and understanding of the disease as well. Because what we tended to find was, particularly with things such as, well, there was diabetes and COPD, we had a lot of patients that were presenting with an exacerbation in hospital with COPD, having a clue what was wrong with them. But through the education from practices and early prevention like this, people are aware, going, actually, I think this is what's happening, and they're not presenting at hospital because they're able to kind of manage their condition effectively themselves. So there's lots in there. I'm going to show you what we're bringing into the live one. It has got practice names, but they're all fake practice names and they're all from all over the place. It's just when we show it to our clinical safety team, they don't like when it says practice 1, 2, and 3 because they don't believe it's real. So the data's all fake, but it's real names from all over the place. So ignore if you notice any, you might be next to a practice in Derby or Surrey or Yorkshire, but don't panic, we're not doing that.
There's another couple of minutes, Lorna.
Yep.
Okay.
We've got these two down here. So this is just what I wanted to show you. So this is one of the Venn diagrams, which is going to say, show me patients without CKD, but do have diabetes. They do have a GFR of under 90 and they do have hypertension. This will let you see that there's currently in the pretend system 21,000 patients that have all three of those factors. So what you're able to do on the dashboard is click on a practice and find out the number that are in that sweet spot. And it's the exact same on this one here. You're able to see everyone with a UACR of less than 3, a GFR of under 60, and they've had a CKD admission in the last 12 months. We've had none in our test data, but in the live one might be different, but it just lets you identify those patients quicker. And there we go. I will be quiet now, but we could go on and on and on. Any questions?
Lorna, that is brilliant. What a great resource for people. And, I'm really impressed with, you've made it look very easy in being able to look at all those different things. And I know it's not often until you get in there that you start doing it. Can you really see and see where the real benefit is when it's your patients, etc., etc. There aren't any questions in the chat, but has anybody got any questions at all from the floor?
I think that's one of the big things you mentioned there, Kate, though, was just about it answers that so what. I think there's loads of tools that say you've got 248 patients that have this, and it's like, aha, who are
what's
they?
Next?
But it lets you see who they are for you to then have that potential intervention.
Chris has got his hand up, and then Barry.
Yeah, hi, Kate. Yeah, I'll ask a question. I mean, obviously, we've done quite a lot of project work in CKD in a couple of different locations the last little while. I think, as we've seen, one of the big challenges is patients with missing UACRs, which is great that you can flag them and narrow in on those populations. One of the others is on the journey towards optimization is patients on suboptimal RASI therapy, or with and I just wonder whether it's possible to isolate those that are perhaps on RASI therapy but not at optimal doses. I think some of the other tools that are out there, like CVD Prevent, show patients taking RASI therapy but don't give any granularity as to whether or not they're on homeopathic dose or not.
We could definitely explore that. It's not something that we've been asked to include. I'll be totally honest, we are very much relying, this is an end user tool, this is your tool, so we have not picked anything to go in here. Everything that's in here has been what Katie and Sarah have not asked for. We've not been able to give them everything. They've asked for a lot and we couldn't do not everything. But it would be, if you want to stick that in the notes, I can definitely take that into our data team just to capture that and ask if we are first of all collecting the data and if we'd be able to showcase that. That's definitely not a problem.
That's just my view. I mean, would it be sensible to have a quick show of hands and see if anyone else thinks that that's sensible?
Will has just put in the thing that he thinks that that scenario is very common.
Yeah.
And we would need to take it through, because we are class 1, it feels like everybody has to sign this off, so it does go to a panel. Sarah's on, there she is. It goes to a panel, so we do, good job I wasn't saying anything bad about you, Sarah. It does go to a panel, so everything that kind of comes through Katie and Sarah have to go to our panel for them to go, no, that's not right.
I suspect Sarah wants to jump in here. So
yeah,
Sarah.
Sorry, before Barry asks his question. Yeah, it's not just my clinical negligence. I don't think, Chris, that I haven't asked for this. It's very, very much dependent on the quality of the coding data, and even still, the issues we've had. This is the screens that I was using to try and pull the SGLT2 data from, and there's been so many issues with that. There's nothing yet that I've come across that allows the granularity of picking out that kind of maximum dose, unless the patient has been coded as being on a maximum dose, and then that's a whole other set of codes that the system will have to search for. So it may well be possible, but that's something I think Milana would have to look into in a bit more detail.
I'm so glad you're wrong, so I don't need to try and explain that to you now. So Grant, we'll pick that up.
Thanks, Sarah. Barry, if you've got a quick question, I'm just looking at time.
Sorry. So Sarah's dead right. It would have to be coded as maximum tolerated dose, or it wouldn't mean anything. Secondly, the SGLT2s, I did have a look at this about 2 or 3 months ago with Kate, and there were low numbers, and I couldn't understand why the numbers were so low. Has that been tackled?
Yeah. So we have then in October the fix will be going in. What it was there was some pesky SNOMED codes that hadn't been picked up. So we've now there was literally I think 4 ones, I think was like 4 or something, wasn't it, Sarah? And with just adding one of those 4 in, the numbers jumped up by like 1,000.
Yes.
So it's much more realistic, the numbers now.
Yeah, and what would be really helpful would be that when you get down to patient level, if you could click on and get historic data, because
we're not allowed to. We're not allowed to.
That, right? No, that's all right. Then that's fine.
We don't have the IG that allows us to hold the historic data, unfortunately.
Right. Because as you probably know, you need 2 readings to make a firm diagnosis. Yeah. But clearly, it gives you the direction to go and look.
But it's not. We can't legally do it. We can hold it.
Sure. Okay. Thank you.
Thanks for those questions. That's great. I'm sure we could talk about this a lot more. Lorna, can you just reiterate, if people want access to this, how do they need to get access?
Yep. I will put the user form in the chat, and if you've got, I'll put my contact details, and if you've got any questions getting access, just give me a chat.
Right, that's brilliant, Lorna. That's great. Thank you so much.
Not a problem.
So we'll move on from Lorna, and we'll move on to Tim, who's going to give it a presentation about Cognitant. So I'll hand over to you, Tim.
Thanks, Kate. Can you hear me okay?
Yes.
Good. Great. Thanks very much for having me here today. My name's Tim Ringrose. I'm a nephrologist and intensive care doctor by background, but my main job is running a digital health company called Cognitant. It was really fascinating hearing from Lorna about Radar, and that looks like an amazing resource. And I guess what I'm going to talk about fits in so neatly, because once you've identified patients with CKD or at risk of it, what are you going to do about it? So let me just share my screen. I'd also just like to say that I'm going to have to shoot after I've shared this with you, because I'm actually at another meeting with West Yorkshire. So, but you probably didn't want me to stay for the discussion anyway. But hopefully you can see my screen. Good. Well, the motivation for Cognitant is to tackle the fact that a lot of our patients and the population don't have a very good understanding of their health, and poor understanding about your health leads to a number of problems. One of them is poor outcomes, health inequalities, but also, very importantly, system inefficiencies. We know that it's a large range, but a lot of the information that we discuss with patients in a consultation is forgotten or confused as soon as the patient's left the consultation. That old scenario of going home to the family, and the family say, well, what did the doctor say? And oh, I'm not quite sure. Or they mentioned a new drug, I'm not quite sure why I'm on that. I'm sure your consultations are all excellent, but unfortunately people forget a lot of things that are discussed. But we also know that when we do provide information to patients, a lot of patients have literacy problems. And so they may struggle to understand the information if it's in written format, particularly when it's quite complicated. Understanding what your eGFR is, or understanding what your albumin-creatinine ratio is not easy, is it? And we know that there are lots of health inequalities, and that leads to poor outcomes, as I mentioned before, but also people who have low health literacy are much more likely to have crash dialysis or other emergency requirements and consume more health resources, but most importantly have worse outcomes. So that was the motivation for setting up a platform called Healthy Note. This is a digital platform to deliver information that's accessible, that's personalized, and that people can trust. And I think it's important to acknowledge that artificial intelligence is transforming information, but not always in a good way. And so I think it's really important that we provide patients with information that we can recommend to them wholeheartedly, and that's not going to mislead, because we know, unfortunately, that there's a lot of health misinformation or disinformation and online, and sometimes AI doesn't always help. So the way that the Healthy Note platform works is that it's controlled by the clinical team. So it's up to you to decide what you want to send to the patient, the person. I can show you how that goes in a second, but that's usually either a text message, an email with a link, or it can be a QR code on a leaflet. And what we do is we build programs on the platform, a little bit like Netflix films, I guess, so that the person that we've sent that out to can view it. And I'll show you the chronic kidney disease one in a second. So it's a very simple concept, isn't it? But like all things in life, it's much more complicated to make it really work. And like any innovation, to get it really working, we need to focus a lot on the dissemination, engagement, and implementation of it. And it's been great to work with NENC and the Health Innovation Network and the Renal Network to work out how that's going to happen. That's such an important thing, because of course it's got to spread across the primary care and the community and specialist services. But we also have integrations with clinical systems. So in some ICBs, patients are getting text messages through doctor, or patients know best. And it'd be good to hear from you which integrations are going to be most useful to you. We are also DTAC certified and approved to be used by the NHS, and we have NHS login integrated. So if a patient chooses to, they can use the same credentials that they use for the NHS app to log into our platform. But in actual fact, for the program we're going to talk about today, login's not necessary, because I think it's really important to make this really easy to access. So here's the Kidney Essentials program. So this is one of the programs on the platform. It's a program that was developed with a renal unit in Berkshire, near Oxford, and it's very visual. You can see some of the video here. We use 3D models and animations and avatars speaking different languages to explain where your kidneys are, what they do, what does CKD mean, what are the different tests, and what do you need to know. If your eGFR is 40, what does that mean? Oops, sorry, my sharing has just suddenly stopped. Let's go back to that. And having built it, it's now being used by a number of ICBs, and we're really pleased that it's part of your Spot CKD program in North East and North Cumbria, and we're looking forward to that starting to get used.
If you've not reshared, Tim, yet it's not come back on.
Oh, I beg your pardon. I don't know.
It's all right.
My computer.
IT's great when it works, Tim.
Right. Yeah. How's that?
That's it. It's back. Super.
Good. So I thought you might like to see what it looks like. So this is the version for North East North Cumbria. You can see it's got the branding of the ICB and the Health Innovation Network, and it's also got Boehringer Ingelheim's branding here, because they've indirectly funded use of this for the ICB. If I click on it, you can see what it. I'm a bit of a slow connection here, but there we go. You can see what it looks like. There's the main part of this is the video.
Interactive guide aims to help.
In the interest of time, I'm going to go through this very quickly. I'll just scan forward.
About what the kidneys do, what CKD is, about tests and checkups, and how the condition may affect your overall health. You can also find out about treatments and simple lifestyle changes that can have a really positive impact on.
And what I'll just show you is how it works if you choose a different language. So if we chose Punjabi, for example, everything will change. Not just the video, but also the navigation, so that somebody who prefers to engage with it in a different language can use all the features. And one of them is a glossary. So it's always interesting to look at a glossary in a different language. I'll switch back to English in a minute, but you can see that we're explaining different terms like eGFR, and go back to English now. So this is an adjunct that can be used as part of the education of patients. Of course, you can use it in the consultation if there's time, but more often it's used as a way to following the consultation for people to use and potentially share with family and friends, because that's often very important. I mentioned about dissemination, and so these are some of the posters that have been developed by the actually, is it the ICB or the HIN that's developed these, Kate? I'm not quite sure. I think they're just awaiting approval.
Yeah, it's collaboration.
Yeah. So these, you can see, have a QR code on them. So as I mentioned before, the best tactics include digital and non-digital methods. So if a person's given a leaflet, perhaps in the practice, they can scan the code with their phone and see the information. It's a web-based platform, but you can look at it on pretty much any device. So it works very well on phones. It all rescales to different size. And the videos all work. And then in terms of what's the impact of this, I think the best way to think about it is that it unlocks lots of benefits. And in Reading, where this has been developed, it's been used by over 4,000 patients. We've got very high satisfaction rates from patients. We're always looking to improve it, of course, and we hope to add new languages and new content. But they've also been able to use it to unlock some efficiencies in their renal clinics. So, of course, these are next stage up when the patients are referred to the renal clinics. They've been able to reduce their waiting time for clinic and see more patients virtually. And they're also starting to see some benefits in terms of the management of patients' adherence to medication and preparing patients and reducing the numbers of patients who crash land. We are continuing to develop more programs, and we're really keen to work with the NHS to develop more and more programs that we can make available. We also work with industry, and you can see that Boehringer is involved in this one. We're currently building a program for hypertension, high blood pressure, which we hope will be available early next year, and starting the process of building a program for AKCC, Advanced Kidney Care Clinics, which is a little bit behind that. So I hope that's a useful tour, and I'm reasonably on the time. Am I, Kate?
Yes, yeah, very good. You've left a couple of minutes for questions. Just to let people know that Mark has put a link in the chat saying that if you want access to the platform, that you can click that web link. So I don't know if there's no other questions in there. Tony says from Nikos, got to love NHS cybersecurity. Yes. So is there anybody else that has got any questions? If not, I've probably got one. Right, well, while people are thinking, Tim, I was just going to ask, in terms of the different languages, do people have to sign up under a certain language, or can they toggle between the different languages when they get the access to the platform?
Yeah, great question. So yes, for the most part, it's about toggling. So you click on the link, you'll see it's in English, and you can choose another language. But there's an important proviso which is worth mentioning. If a user has got their browser set up for a different language, so if they've got their internet browser set up for Punjabi, it will automatically load up the Punjabi version. Right, okay, but they could, if they'd got other members of the family that wanted to speak a different language, they could change it. Right, okay. Exactly. So if in that situation, they'd see it in Punjabi, but if they wanted to change the language, they can just select that toggle and choose another language. Right, interesting. Right, that's great. I mean, it looks a fantastic resource, I have to say, and I'm sure it's one that's going to be used very widely. Is there any questions from anybody else? Or if not, I know you need to get off, Tim, because you've got to go to a meeting in Yorkshire. I'm glad some people can access it. Mark's got access to it. Yeah. Right, okay, well, that's great, Tim. I know you're really busy, and thank you very much for coming along today. We might ask you to come back at a future date when we have a few more people at this meeting, but thanks so very much. Very, very happy. And just one last point. I noticed that Sally's got the Kidney Care UK poster on her screen. We do have links to Kidney Care UK, Kidney Research UK, and the Kidney Research, the Federation content in the resources as well. So it's not about replacing them, it's about augmenting. Yeah, absolutely. Thank you very much, Tim. Thank you. Great. Thank you all. Super. Right, we're now sort of back. Bye. Back on time. So we've now got, is Lynn here, Dr. Lynn Sykes?
I'm here twice actually, but yeah, sorry.
Oh, you're here twice, right? That's all right. That's absolutely fine. So I'm going to pass over to Lynn, who's a consultant nephrologist in Newcastle, and she's going to talk about AKA acute kidney injury in the community.
So yeah, so I was just asked by and well, Alex, really, to share what we were up to in Northumbria and up here, really. It's just so that things are a bit, I suppose, fairer in terms of what we're sharing and what we're up to, so you know what we're doing. So I'm a consultant that works out of Newcastle and come up here to NSEC, where I'm clinical a couple of days a week and see referrals. But it was a question of how that then links out to the community and the work that we're doing across the sort of northeast and Cumbria region in order to make sure that we're standardizing what we do, and so that we're not I suppose mixing messages and taking good feedback. Essentially, I would love for any of your feedback to give us a steer or any sort of inspiration you have in terms of making the journey smoother. The reason why it's useful to talk about AKI and talk about, you know, the continuum with CKD is essentially, you know, all my own PhD work looked at AKI, and AKI events are just associated with a more rapid CKD deterioration. When you look at patients who've got CKD, one AKI episode has a 14-fold increase risk of putting them on dialysis. Sequential AKI episodes, you know, double that risk up to 28-fold, and each sequential AKI is much more likely to be an AKI 2 or 3 once you've had an AKI and CKD. So, you know, the risks of complications are actually much more severe. And as we all know, you may well have an AKI and not get back to your baseline CKD in the first place. So it's really important that it's actually considered as a continuum as well, as actually, you know, smoothing out those transition periods between secondary and primary care, essentially. From what we've been doing, I suppose, up here, Connect NENC is a digital system that we've been using to help refer AKIs between secondary care. And the reason I mention it is that actually it has improved communication remarkably, but also it's going to be appearing more and more in the GP and across sort of the Great North Care record as a PDF upload, so that you will be able to see directly what Renal have said in the notes, but also then, you know, there's a robust follow-up process on closing these, so that there is an actual end to care, so that if someone has been referred, not only will there be an outcome, but there'll also be then, you know, clicked as follow-up, you know, does not require renal follow-up or may require renal follow-up if these circumstances are met, or has been referred directly into new patient clinic, and that would just be a lot more clear, which I think is really important from you know, a patient journey point of view, as well as a governance and audit point of view as well. Some of the things that I've been doing, so I ran an AKI masterclass in Northumbria yesterday. At the Healthcare Academy, the team up here are really keen for more and more sort of educational resources. So we have developed a national resource that I can share with you if you're interested, but also from our side of things, I've spoken at GP Excellence events. I've been repeatedly asked to deliver education, and we've now supported that with some follow-up e-learning as well, so that there is sort of an ongoing process in hospital that can then be shared with primary care, and it depends on, you know, the asks and the integration in terms of what would be helpful and what would be useful, that we can then, you know, flex and develop or invite you to join. Things that are under discussion and development are things like the post-AKI pathway. So whilst there's been some collaboration between the RCGP colleges and Society of Acute Medicine, for example, it is important to make sure that regionally we have a relatively standardised suggestion of processes that mean that we're not, you know, dumping patients out of hospital with AKI with either no plan or see your GP in, you know, 26 hours to have a repeat blood test. So it's really important that those, you know, have some parent team ownership and make sure that we're not, you know, losing patients in the pathway, but making sure that they get the appropriate follow-up either with their own team or at appropriate junctions down the line. some safer transfers across hospitals may well also include some interim communications, is what I would call it, to the GP. So should a patient have an AKI in critical care environment, or an uploaded patient path, so communications between the teams, it may well be that you get an interim update that your patient has had a disaster in hospital and has ended up on dialysis and is recovering, or therefore you may well get interim updates. But again, it's just to smooth that through. And again, it's about broader dissemination slowly, and a discussion for feedback around more information around what you would like and what you would like us to provide you with, because this is not unidirectional. This is identify areas and touch points where it would be useful for us to collaborate or have your feedback and input on. From our side of things, we are also going to be doing some Melissa bus touring. So this was more the fact that I'm relatively new to the region and I had no idea the Melissa bus existed, but we're going to be going on a little tour as well, certainly around Northumbria region. But again, it's a useful tour. It has, the Melissa bus itself is an educational tool, has audio visual, set up on it, so you can put anything that you want up on it in terms of having rolling programs of education. And it may well be something that's applicable to perhaps promoting urine testing or whatever else that it may be from a CKD point of view. So it's just a nice opportunity to promote that as well. And from my point of view as well, that this is the previous RCGP agreed pathway, but again, it's trying to develop something that works across the northeast and North Cumbria, and trying to figure out a way that means that patients who've had an AKI and perhaps have heart failure or a high risk episode and are likely to go on to have CKD, or likely to need care in the future, have an opportunity to have a standardized pathway. And most of our opinions fit with AKI follow-up is entirely the responsibility of the parent team, particularly when it comes to things like heart failure, and rapid follow-up and titration of diuretics is important, rather than sending them out and suggesting that they catch their GP whenever they can. So it's just that we would like to think about how we might standardize this, or use this as a framework that may be of some use, but also suggest a sort of a responsibility framework, shall we say, to ensure that we've got the right parent teams looking after the right patients, so that the patient remains the centre of the care and gets the care that they need sort of continually thereafter. I think that's all I wanted to tell you about in terms of what I'm up to. So, like I say, this was just I was just asked to update what I've been up to. So again, happy to take any feedback, happy to take any collaboration, and like I say, I'm just keen to develop some standardised and safe pathways to move forward.
That's great. Thanks for that's a really sort of succinct and clear update, Lynn. I suppose really a couple of questions from me. If you're open to sort of dialogue and collaboration, what's the best way for people to get in touch with you? Is it just to email you on your email address that you've just shared?
Yeah, I'll put it in the chat now. But yeah, totally.
Yeah.
And I guess I mean, I don't think I'm happy to talk about anything, but I think from my point of view, it's just around keeping those dialogues open. If things are working, not working, I want to hear the feedback. If people think that things look like that's going to be a disaster, please don't do that. I'd love to hear that, because I think enthusiasm runs to a point, but actually you've got to find a way that lets everybody do their job a bit more efficiently, rather than asking them to do an extra thing.
So can I just ask, in terms of the post-AKA pathway, is there a date for this to be done, or
no? So that's the original version that's been developed probably, it must be about 5 or 6 years ago that was developed. So right. But it's a suggestion, and again, it's it's not a standardized you must do this. It's how would we feel about creating something maybe slightly simpler, but just to kind of again give people a rough framework and standardization across the region as to what we're doing with AKIs dropping out of hospital, because obviously the variation is huge, and some of it's appropriately so. Not all patients aren't necessarily going to be appropriate for up titration of everything, but then, you know, likewise, it's trying to make sure we're not missing people.
Brilliant. Sorry, one more last question from me because nobody else has got their hands up. But the Melissa bus.
Yeah.
So have you got? You know, we use buses for outreach work. In terms of the Melissa bus itself, have you got? Are you planning to use it in a certain way? Is it to do some testing like UACRs, or is it to go out and do education, or have you not sort of decided what you're going to
ours
do
is
yet?
for education, so that's our plan
Education.
for education. You know, it's at the moment the plan is to use it for promoting the e-learning that we've developed for the Northumbria Trust. But again, you know, totally. I just think it's a really nice idea, you know, to essentially have the opportunity to go out to the people to you know, because we don't often have as much contact with the district effectively hospitals from NSEC, so the setup is very different up here in terms of, you know, acute hospital hub, and then the, you know, the surrounding hospitals don't have as much face time, shall we say.
Right, yeah, no, understandable. Right, okay, that's great. Thank you very much. Has anybody got any other questions for Lynn? No, right, okay. Well, Lynn, thanks very much for your time and sharing your presentation. That's been really useful, and hopefully, I'm sure everyone's found that interesting. We're just going to move on towards the last little bit of for the last sort of 15 minutes or so. This is our sort of first community of practice for CKD, sort of changing the format from how it had been run previously. And really just wanted to open the floor in terms of thinking about potentially suggested agenda items or presentations that people might like to hear. I've got a couple of suggestions. Whether there's some reflections as well in terms of how people think that this might run, and whether this is going to be something that might be a bit too early to judge that. And I can also highlight some resources as well. So I don't know if anybody wants to kick off on any of that. Sarah.
I'll jump in if that's all right. Okay, thank you.
Yeah.
So obviously we were hoping to use this group to bring together enthusiastic individuals from across the region that might be interested in standardising and improving CKD care. What we would like to do, so my other role is that I'm the CKD lead for North East North Cumbria Renal Network, and what has been on my to-do list for some time is to try and pull together some CKD regional guidance. Now, Will Billis, who's also on the call, is one of our pharmacists who's working with us, has been incredibly proactive on this. But what I'd like to do is use this group possibly to promote that work, and maybe have an offshoot working group for that. So if anybody was interested in development, essentially, you know, we're looking at a higher level 1 to 2 page CKD guidance that is applicable to everybody across the region, predominantly aimed at primary care users to simplify medicines optimization, frequency of monitoring, when to refer, etc. So if anybody would be interested in working on that with Will and myself, then please get in touch.
We can also, Sarah, send that out to Christine, to the people that are here, and obviously other people that join as well, and see if we can get, you know, contact people separately as well, Sarah, so we can see if we can get a small working group. Super.
Excellent. Thank you.
I think that would be really good, because that's something that's really productive, something tangible that's going to come out, that's going to help in terms of the aim of what you want for this, Sarah. So I think that would be really good to be able to do that. I mean, I do note that the numbers have been pretty steady throughout this meeting. So, you know, people haven't really dropped off. People have come and they've stayed. So I think that that's really good. Right, okay, brilliant. Will has also put they can email him if interested as well, so that's great. In terms of resources and things, there are a lot of resources on the Health Innovation North Cumbria's CKD webpage, and that includes things. I had to write them down because there were so many. There's a myth-busting document, myth-busting CKD in primary care document. There's links to previous CKD educational webinars. There's also signposting. So there's the Kidney Care UK's #BloodyAmazingKidneys campaign. There's some patient resources. So there's a number of different things on that website. And I think, Christine, you might be able to sort of pop that in the chat. In terms of the renal network, it might be worth Alex picking that up next time so that he can go through some of the resources, because there's a whole host of resources on the renal network website as well, webpage. So I think Alex could probably pick that up next time, which would be good. In terms of agenda items for next time, now, I'm not putting anybody on the spot here. There's a couple of suggestions. So Dr. Will Hinchcliffe, a renal consultant at STSFT, he's been doing some work and he was wanting to come along and present at the Durham CKD project. So he could be one of our next presenters at the next meeting. And then there was Dr. Ian Logan, who's a consultant nephrologist in Newcastle, who's done work on patient information leaflets on SGLT2s, but that was developed in conjunction with Kidney Care UK. So those are two potential that we could have next time. If there's any other thoughts or anybody's got anything else that they think that I've done something really interesting and I want to share it with this group, please get in touch with Christine and she would be able to help facilitate that. So, you know, put your thinking caps on, but those are two presenters that we could have at the next meeting. And then in terms of the next meeting, it is the 20th of November, not the 25th. We will send a correction out on that. I want to check with people, are Thursdays at this time a good time for people? I know we're never going to get a great time for to accommodate everyone, but for the people that are here, I'm presuming because you're here that probably 3 to 4 on a Thursday afternoon works for you, but I know it might clash for some people with school pickup. So Sarah,
this does work for me. What I was thinking though is particularly for primary care colleagues who are going to be sat in packed clinics morning and afternoon, lunch times might be slightly more accessible, which often means I might have to like turn my camera off while I have my sandwich while everybody's talking, but you know, it might be easier for some people to attend on a lunchtime.
Yeah. And I think that's a really good point, because we are wanting to sort of open up and encourage more primary care sort of interested folk to attend. And I think probably, and we tend to do a lot of our sort of webinars and educational stuff at lunchtime, so people can turn up, sit with their cameras off, eat their lunch, you know, and hear what needs to be said. And we do get quite good engagement from that. So what I would propose then, bearing in mind what you've said, Sarah, and what we know, should we move this to a Thursday? I'm going to say Thursday lunchtime. We've got quite a lot of other things to do, but we could do a Thursday lunchtime, or would any other day of the week work better for people? I'm not thinking Fridays and Mondays are not good for people, certainly in primary care, but we could do just carefully pick our Thursday lunchtime. Sarah's nodding. Everybody else has got their cameras off, so I don't know whether that's because people are doing something else.
Good idea. I think that's a good idea, Kate. I think Thursday lunchtime. You know, these meetings are bi-monthly, aren't they?
Yeah.
So I know that there are some other things that happen at Thursday at lunchtime, but considering it's only kind of every other month, I think that should be fine.
Yeah. Okay, well, Barry and Rebecca put their thumbs up, so I might have missed if somebody else did. So that seems to be a bit of a consensus there. We're going to go for a Thursday lunchtime. So it might not be the 20th then. We might change whatever that date is. We'll have a look. So I think, unless anybody has got any other business, has anybody got anything? Will, you've got your hand up?
It was just a quick one, Kate, just in terms of people getting people invited to present. Is it specifically from our area, or can we, you know, invite people from different areas to bring some good ideas to the plate?
Yeah, Sarah's nodding. I would think, you know, quite often it's, you know, I think what we want is a rich environment to stimulate people's thoughts and thinking about being able to innovate and all the rest of it. So yes, I don't see why not. Okay, thanks, Will. Christine, you've got your hand up.
It was just a very quick one, Kate. It was just to mention about possibly moving these sessions to Eventbrite rather than being kind of a Teams meeting. So it was just if people not to panic if the Teams invite gets cancelled. But I think going forward, had a meeting with Alex just before he went on paternity leave that Eventbrite would be a better forum where people do register their interest. They'll all still be recorded, but it's just a better forum to kind of host these meetings.
Right, okay. Right, is that okay with people? I think I understand why I want to do that. That would probably be easier in terms of an admin way of doing it. Yeah, okay. So if people are okay with that.
Apart from Barry.
Apart from Barry. Okay, well, we'll look at doing that and putting it onto Eventbrite. I noticed Diana's put something in the chat regarding preventing cardiovascular renal metabolic disease and GDMT. It's a lunch and learn session on 23rd of October. So if people are interested in that, by all means, have a click on that. So unless there's anything from anybody else, now's your last chance. No? Right, well, I would like to thank you all for your time, and for anybody, if the presenters are still here, thank you very much for your time and coming along today and sharing all your experience and knowledge. And she'll look forward to seeing you again in November. So take care, you've got 4 minutes back. Thanks, everybody. Bye-bye.
Thanks. Thank you.